Good. Well, it's my pleasure to introduce Dr. Angela Campbell, and she is, I'm afraid I have to read these things out because I can't remember them all, and they're so extensive and impressive, but her NHS post is as Consultant Physician and Clinical Director in Medicine for the Elderly in South Glasgow. Also Honorary Clinical Senior Lecturer at Glasgow University Medical School and a Director of the Scottish Council on Human Bioethics and a former member of the British Geriatrics Society Policy Committee. And she will be speaking on ethical dilemmas and increasing challenge in the work of a geriatrician and covering some of the very practical areas that are involved in that. So, Angela, it's very good of you to have come all this way from Glasgow.
Thank you, Bishop Hugh, for that introduction. I hope what I say will complement and follow on from your excellent overview of the issues about euthanasia and dying, particularly from the Christian perspective. I'm a geriatrician, and I suppose maybe I should define what is a geriatrician. A geriatrician is a general physician who specialises in the care of the frail elderly. And as a geriatrician, I need to be aware of the legal aspects of medical treatment, particularly relating to capacity and consent, human rights, guardianship, and ethical conundrums such as when to investigate, when to treat, and also when not to investigate and when not to treat. As Bishop Hugh has already mentioned, the elderly in society, their place in society is changing. The over 85 population is the fastest growing section of society in this country, and the health economists have voiced concern about the financial implications of this, particularly the potential cost of health and social care for the frail elderly population. As a doctor, my practice is governed by the 4 core principles of medical ethics. As Bishop Hughes already mentioned, the concept of autonomy or self-determination. That's the first principle. I think we have to be wary about autonomy because a person's ability to consent or decline to treatment may well be influenced by the information they're given about that treatment. It might be influenced by their mood, by their cognitive state, and by their value of themselves in terms of the relationship to society in general. So it's certainly not uncommon for older people to say to me, I don't want to be a burden in my family. It's time for me to go. I've had my life. I'm past my sell-by date. And we have to be very cautious that society doesn't make older people feel undervalued. The second principle of medical ethics is justice, fair allocation of health and social care without discrimination. So again, we should not discriminate on account of age or on account of any other reason. Beneficence is fairly simple, do good, and I think we would agree that doctors should do what they think is beneficial to their patients, and the opposite of that is non-maleficence, so do no harm. There are a number of ethical challenges in geriatric medicine that I will touch on. I think we've already talked about withholding and withdrawing treatment, particularly enteral or clinically assisted nutrition and hydration. There's also the issue of cardiopulmonary resuscitation, this sort of electric shock treatment to restart the heart if it stops. Consent and mental capacity is a growing issue, particularly with the increasing prevalence of dementia and cognitive impairment amongst the frail elderly, which diminishes their ability to make autonomous decisions. There's the issue of advanced directives or living wills. How valid are these? Are we legally bound to adhere to them when they have been drawn up by an individual often many years previously, when it may be difficult for them to envisage how they might feel if a certain disability were to affect them. And it's amazing how many people actually, when that disability does affect them, actually have quite different views to what they'd previously stated. And so there is a risk with advance directives that it might actually result in that individual being denied treatment that they might otherwise benefit from. And finally, euthanasia has already been described a good death, a happy death, which is certainly not what if you read in the media or about euthanasia, everyone thinks it's to do with killing, not a good death. I'm not going to go into a lot of detail about euthanasia, certainly not about active euthanasia, because it is illegal in this country. But I will touch on some issues relating to end-of-life care, where there is a question mark over the possibility of the action or lack of action being interpreted as euthanasia, be it active or passive. So first of all, I want to say a little bit about mental capacity. How is it defined? Well, an adult is capable if he or she has received information to make a decision, is not under pressure from someone else to make a decision one way or the other, if they can communicate the decision and consistently hold to that decision and don't waver or forget or change their mind repeatedly. And the opposite, obviously, is mental incapacity, where the adult cannot act or make decisions or communicate the decisions or understand the decision or retain the memory of the decision because of mental disorder or inability to communicate. So that could be a patient with dementia, a patient with delirium, which is an acute confusional state, someone who's in a coma, or someone who's had a stroke, who is unable to understand speech or the written word. Mental capacity is not all or none. So a patient with dementia might well be able to make a decision about whether they take sugar in their tea, but not make decisions at a more complex level. In Scotland, the legislation currently governing capacities issues is the Adults with Incapacity Scotland Act, which was passed by the Scottish Government in 2000. And it is really to safeguard the adult who lacks capacity, so that others are not making decisions without taking into account what is in their best interest. And the general principles of the Act is that we have to take into account that person's past and present wishes, if they're able to voice them, take account of the views of relevant others, and try to use the least restrictive option possible. As a doctor, I think often we have to make decisions on behalf of patients who are unable to make decisions for themselves, often because of dementia or other mental disorder, or someone who's had a disabling stroke. I think if that individual has a welfare power of attorney, which had been set up previously when they were well and competent and able to express the wish that that individual would take responsibility for their welfare decisions if they lost the ability to do it, then we would respect and certainly take into account the views of that welfare power of attorney. If there's no welfare power of attorney in place, we have to go through what is currently quite a laborious guardianship process, whereby two doctors have to independently confirm that that individual lacks capacity. There has to be an independent report from a mental health officer, and then the case is heard in the Sheriff Court, and if the guardianship order is approved, it is registered with Office of the Public Guardian in Falkirk, and usually the person who applies to become a welfare guardian is the next of kin, but in those who don't have any living relatives, it's often a lawyer or a social worker. That process can take up to 6 months, and in some parts of the country longer than that. So it can be often decisions about patients leaving hospital, going into care homes are delayed, and a number of these patients account for what we call bed blockers. And I think the legislation perhaps will be changed in the future to facilitate these decisions being made, because it's certainly not in a patient's best interest, if they're fit to be discharged physically from hospital, that they're detained until this legal process is pursued. If a patient comes into hospital as an emergency, we treat. We do not need to get consent for treatment, for potentially life-saving treatment. But any other treatment in an adult who's unable to give informed consent has to be in consultation with a proxy decision maker, as I say, either a welfare guardian, power of attorney, or next of kin. What guidance do doctors have in these issues? Well, we've got the Hippocratic Oath, which medical graduates take, and that includes the phrase, no intentional killing by act or omission. We've also got professional bodies like the British Medical Association and the General Medical Council. There was a joint publication in 2007 from the British Medical Association, Royal College of Nursing and Resuscitation Council UK on decisions relating to cardiopulmonary resuscitation. And we also have guidance from the General Medical Council in 2010 entitled Treatment and Care Towards the End of Life, Good Practice and Decision Making. That guidance is currently being updated, and the updated version will be published later this year. It's interesting that in that GMC document, I quote, it says, serious or persistent failure to follow this guidance will put your registration at risk. So the General Medical Council, which is the body that regulates doctors and has the power to strike doctors off the register and thereby make them ineligible to practice medicine in the UK, it's quite a powerful regulatory body. So what does the GMC guidance give me as a geriatrician? How does it help me in making decisions at the end of life? And how consistent is it with the Christian perspective? And I'll give you a few quotes from the guidance. Good end-of-life care helps patients with life-limiting conditions to live as well as possible until they die, and to die with dignity. By end-of-life conditions, they give us an example, progressive conditions. That could be heart failure, kidney failure, lung failure, cancer, dementia, or acute catastrophic events such as a massive cerebral hemorrhage. And they also mention persistent vegetative state as an end-of-life condition. They also say most difficult decisions are around starting or stopping potentially life-prolonging treatments, and requires the clinician to weigh up the benefit versus the burden of care. These principles are based on the Human Rights Act, and there is a presumption in favour of prolonging life. So if in doubt, treat. We should offer treatment where the possible benefits outweigh the burdens or risks, but we should avoid treatments which will not work, provide no overall benefit, or have been refused by a competent patient. And if the patient is incompetent, then we must consult a proxy decision maker, the rest of the healthcare team, take into account any advance directive, and if necessary, seek legal advice. We're also advised to refer to relevant clinical guidelines for specific conditions, seek an opinion of a relevant specialist if the potential for treatment is not in our own specialist area, if there may be new treatments that a specialist may be aware of that we are not aware of. It's vitally important that we communicate effectively with the patient or relevant others to ensure realistic understanding of the expected outcome and benefit, burdens and risks of intervention. This is particularly the case with, for example, cardiopulmonary resuscitation. People see cardiopulmonary resuscitation being performed in television, and everyone by and large, people come around quickly, they survive. The evidence is that in frail elderly patients in hospital with multiple comorbidities, the chance of survival after cardiopulmonary resuscitation following a cardiac arrest is virtually nil. In fitter adults, the success rate rises, but it's still the minority of patients who survive. It's not the majority. And I think if people are given that information, it helps to understand why it might well not be in the best interests of that individual to attempt cardiopulmonary resuscitation, which may cause trauma, and it may also, you could argue, have a negative effect on dignity at the end of life. I think, though, the guidance also says if a patient is incompetent and there is uncertainty about the overall benefit, treatment should be started, reviewed, and later stopped if ineffective or too burdensome. And in an ethical sense, withholding and withdrawing treatment are the same, but withdrawing treatment is often emotionally more difficult. And I think we would all agree with that it's always more difficult to stop treatment that you've started than to make a decision not to start it in the first place. The guidance specifically on clinically assisted nutrition and hydration, I think this is an important area because often towards end of life, patients naturally lose appetite, become less inclined to eat and drink. They may become drowsy such that if they do try to eat and drink, there's a risk of them choking, aspirating, and that could cause significant distress. I think, though, there are some patients with who are not at end of life who may also have difficulty swallowing, and perhaps or food refusal in the case of patients with dementia. And we have to weigh up in all these patients the benefits versus burdens of providing nutrition by another route, which usually means nasogastric tube feeding, which involves putting a fine flexible tube up the nose down into the stomach, or a gastrostomy tube feeding, which involves an incision in the abdominal wall, and the tube is actually inserted directly into the stomach and stitched in place. It's a more invasive procedure, and the feeding is provided in a liquid form. What the GMC says is we need to assess the patient's nutrition and hydration status and ensure that this is optimised where possible via the oral route. And if the patient's unable to maintain adequate nutrition and hydration, we should consider use of intravenous or subcutaneous fluids and enteral nutrition. And this statement, which again leaves us uncertain, is, quote, "The current evidence about the benefits and burdens of these techniques in treating and managing patients towards the end of life is not clear-cut." And that's the GMC guidance. So it really is leaving us very much unsure. In certain conditions, someone who's had an acute stroke, they may lose the swallowing ability immediately after the event, but it often resolves within a month. And so in that situation, clearly, with the prospect of recovery, we would endeavour to provide nutrition using a tube method. In severe stroke, where someone is unconscious, particularly if there's evidence of pressure on the brain, the chance of recovery is so low that you could argue that actually tube feeding is not in that patient's best interest. With suppressed conscious level, that patient is more likely to regurgitate and aspirate. And the evidence is that most of these patients die. In dementia, if patients are refusing food rather than having a swallowing problem, the evidence from a number of randomised controlled trials is that whether you tube feed these patients or not, you do not improve their mortality. And the policy may be, if it's food refusal, to encourage oral feeding as and when the patient will allow it, rather than to put in a gastrostomy tube. It can be extremely difficult. I've had patients in whom we've put in a nasogastric tube and they've pulled it out. We've put in a gastrostomy tube and they've pulled it out. But their level of awareness of what that tube is doing is probably low, and it's extremely difficult because do you reach a stage where you say, well, is it ethical to sedate that patient to keep the tube in? And I would say no, you're compromising the quality of life. But again, you cannot give nutrition and hydration by any other way, and that's where I think the burdens and benefits and what is practically feasible, and what we can strive to try and deliver nutrition and hydration. But there are certain circumstances where we've tried all options and we're not succeeding. I think medicine, it was much easier in years gone by when we couldn't do these procedures. It's only in the past 20 years or so we've been able to do gastrostomy feeding. And before then, if patients couldn't swallow, yes, we could try and use a gastric tube, but we didn't have any other option. I think the more options we have, I think the more difficult these decisions are going to become. I'll say just a few words about euthanasia. Killing is murder, and assisted suicide a criminal offence. A competent patient can refuse treatment, so a competent patient can refuse treatment that could be life-prolonging. I've had a couple of patients who have decided to have been on kidney dialysis, renal dialysis, who have decided that they did not wish to continue with that, knowing that if they stopped it, they would die. And we have been in a situation where we've had two consultants, a kidney specialist and myself, for example, ensuring that the patient wasn't depressed, that they were making the decision autonomously. And we had to respect that decision. We could not judge whether it was the patient was making that decision for the right reason, but we had to respect their decision because it was an autonomous decision. And that can be difficult. You may think that someone's not making the decision that you would make in that situation, but if they make that decision, we have to respect that, as long as we can assure it's an autonomous decision, not made when the patient has been influenced by others. And in one particular case, the patient was found the burden of dialysis greater than living with her kidney failure and letting it take its natural course. Again, in years gone by, we didn't have the techniques of dialysis, and people with kidney failure died. Again, an example where we have an intervention now that can save and prolong lives, but some individuals may decide that the burden of that treatment is too much. That would be a more difficult decision, and it is difficult decisions faced by renal physicians all the time in patients who maybe are on dialysis, who then have a stroke that renders them incompetent to make decisions and they cannot speak for themselves. So who decides then? Do you continue dialysis? Do you stop dialysis? What do you do? I think we always have to adhere to the principle that when patients can't decide for themselves, we have to have this balance of weighing up the burden and benefit. And sometimes withholding burdensome treatment is the right thing to do if that treatment may prolong life by a short time but cause the patient suffering in some way. Also, we can provide palliative treatment that could potentially shorten life. That's called the doctrine of double effect, where someone is in severe pain and you give them a dose of morphine to relieve the pain, but the side effect of morphine might be to cause a little respiratory depression, which could potentially shorten life. Although the evidence, as far as I'm aware, is that in the doses that would be given routinely, there is not a significant effect in terms of respiratory depression and shortening life, unless it's in patients who already have respiratory problems. I think we have to bear in mind also the burden of care versus the sanctity of life. I think we have to respect life. We should never attempt to hasten death, but we have to recognise when a patient is dying and accept that, as Bishop Hugh said, that death is inevitable. It will come to us all at some stage, and we shouldn't be striving in an overzealous way, in an unrealistic way, to keep that individual alive when death is the natural consequence of either a disease process or extreme age. We have some patients who die in our wards who are well over 100 years old, and what do they die of? They die of frailty and old age, and sometimes that's all you can put on the death certificate. And I think we've already mentioned this term slippery slope, and I think particularly with older people, do they have a right to die, or will they feel they've got a duty to die? I really am becoming a burden, and there's an expectation, and I think there's always a risk that not just elderly people, but patients with certain disabilities and handicaps may feel that pressure from society. I want to say a little bit about the Liverpool care pathway, partly because it's caused such a lot of controversy. In fact, when I was coming up in the train from Glasgow, this is today's BMJ, the 2nd of March 2013, and the front page says Liverpool care pathway, still the doctor's choice. And you probably can't read some of the headlines from the popular press include statements like hospitals bribed to put patients on pathway to death, doctors to act on care pathway, district nurse put my father on death pathway. Again, the Liverpool care pathway was developed in Liverpool, not surprisingly, by a group of palliative care doctors based in acute hospital and in the Marie Curie Hospice. The hospice movement developed in Britain, and I think is recognised worldwide as really the optimal way of caring for patients at the end of life. Patients who have the privilege of being cared for in a hospice have a very holistic approach to their care, not managing just physical symptoms but mental distress, emotional upset, and also spiritual care, whether or not they have a faith-based belief system or not. And I think the hospice doctors recognised that most people don't die in hospices, and many people don't die at home. The majority of people die in an acute hospital. And acute hospitals are designed to get people better. Doctors in acute hospitals don't cope well with people that are dying. As a junior doctor, I remember patients who came into an acute hospital and it became apparent they were dying. They were put in a side room. They weren't seen by the consultant of the ward round because there was nothing more we can do. Often communication with the patient and their family was very poor. Symptoms weren't well managed, and patients often died a lingering death, often with junior doctors taking unnecessary blood tests and not being quite sure what to say, and I'm sure these patients were left feeling quite neglected at that time of life when they really needed to have the support of the people looking after them. And I think society in general we're a bit in denial of death. I was reading in the BMJ as well about a conference being held to try and improve end-of-life care and decision-making, saying that we are very good at antenatal care, but we really don't prepare people who are dying or who are likely to die for death. We're always striving to get them a bit better, treat their symptoms, but not to prepare them for death. Anyway, that was a bit of a side. The Liverpool care pathway was designed to try and replicate hospice care as best as possible in an acute hospital setting. It's a care pathway which really requires consent of the patient if they're able to consent, or their next of kin, the agreement of the multidisciplinary team that the patient is dying, and it is a care plan to optimise symptom relief and to remove burdensome care. The criteria for use include the fact that the potential reversible causes for the patient's condition should have been considered and treated. The team looking after the patient agree the patient is dying, and they must have two of the following: be bedbound, semi-comatose, unable to take sips of fluid, and no longer able to take tablets. The care pathway, when used as it should be used, is excellent. And in fact, the article in the BMJ this week will be the basis of a Channel 4 dispatches programme on this Monday evening coming, looking at the Liverpool care pathway. It was a survey of doctors, particularly palliative care doctors and other specialists, asking about whether they would like to be treated in the Liverpool care pathway, whether they would like their relatives to be treated on that pathway at the end of life, and also whether they thought that the adverse publicity in the media had affected the use of the pathway. And the majority of doctors, the vast majority, said they thought it was an excellent tool, but yes, they thought that the use of the pathway had been adversely affected by the media coverage. And why did the media come out so badly in the LCP? I mean, there's been quotes in the media that this is a pathway to death, that it's actually neglect, not care, that hospitals are being paid financial incentives, particularly in England, to put patients on this pathway, and that perhaps it's to try and hasten death because of pressures in bed occupancy. All of these are untrue. And I mean, the Daily Mail quoted, the NHS kills off 130,000 elderly patients every year on the Liverpool care pathway. So, I mean, patients and potential patients reading this in the media are absolutely alarmed. And so the Liverpool care pathway is now seen as a bad thing by the general public, and who are very sceptical about it. And as a result, doctors in hospitals, I thought, we won't go there, we won't even mention this, let's just carry on treating the patient as we used to do. And I think as a result, some patients have missed out on potentially optimal care. I think the problem is that the care pathway was introduced in some hospitals without the staff being trained in its use. The initial versions of the care pathway were worded in such a way that, shall I say, those who perhaps felt that accelerating a patient's death would be in their best interest, there was a loophole that would allow them to do that, because it did recommend initially commencing patients on morphine from the start, whereas revised versions have said you only prescribe morphine and other drugs, sedative drugs, on an as-required basis. There was a debate in the House of Commons in January about the Liverpool care pathway, and actually the outcome of that is that there's going to be a Department of Health inquiry into all the alleged instances of misuse of the pathway. And hopefully out of that will come more resources to actually improve training in the use of the pathway in hospital. We need to recognise that it actually adheres to ethical principles. It does not aim to accelerate death, it aims to enhance the experience of dying for the patient and their relatives. But there should be a regular system of audit of its use in hospitals to ensure that these principles are adhered to. Certainly in a recent review, the key messages from the group that actually wrote the Liverpool care pathway was that it's only as good as those who use it. It shouldn't be used without education and training. Good communication is pivotal to success. It neither hastens nor postpones death. The diagnosis of dying should be made by a team, and the diagnosis of dying can be one of the most difficult things to do. I've seen patients who were dying, who were alive a year later, and that's the difficult thing, particularly with conditions in an acute hospital setting. We have to make sure that patients have time to recover and that we don't diagnose dying too early. Liverpool care pathway does not preclude clinically assisted nutrition and hydration. Because it recommends withdrawal of unnecessary treatments. Again, the view is, and it's been debated as to whether clinically assisted nutrition and hydration is medical treatment or basic care. And that, the GMC guidance is rather vague about that, but it allows for continuation of these if it is deemed to be relieving symptoms. I think in general in a healthcare system, how do we assess quality? There's been a lot in the media about the Mid Staffordshire public inquiry about alleged poor standards of care, lack of dignity in one particular hospital. And it makes I suppose it's prompted health boards elsewhere to look at their own hospitals and look at how they compare. And we often measure quality and outcomes in healthcare with how efficiently and effectively we treat the sick. We look at length of stay in hospital, we look at how many patients we treat, how many outpatients we see. We don't measure compassion, we don't measure respect for dignity. And these are things that I think are important outcome measures in terms of quality. And I think we also need to look at how competently and compassionately we care for dying patients in hospital. I'm going to just mention a publication. I think it might be worth watching that TV programme on Monday night, but there's a very good Catholic Truth Society publication from 2010 called A Practical Guide to the Spiritual Care of the Dying Person. As well as covering the spiritual care, though, it does cover the areas of end-of-life care, including clinically assisted nutrition and hydration that Bishop Hugh alluded to, and it gives the Catholic Church's view on these issues. And it's a small booklet, it's only 35 pages, and I would commend it to you. I'm going to pause there. I've got a few cases. They're clinical cases which I could run through. I'm aware time's going on, so I don't know whether you'd rather just take some questions or give a couple of cases maybe, because just a couple and that's all. Yeah. Right, which ones will I select, just being controversial. Right. This is a case, and these are real life cases that I've come across over the years. An 81-year-old lady who's got mild dementia and depression, and I emphasise mild. She's admitted from a residential home with a fall and a hip fracture, and she had that repaired surgically with no complications. But she didn't get back on her feet. She didn't get out of bed, and she refused to eat and drink, refused to take her medication, and said she wanted to die. And the relatives said something must be done. So what do you do in that situation? We have to assess her capacity. Is she capable of making autonomous decisions to refuse? Is she more depressed than usual? Is the whole trauma of the hip fracture surgery made her more depressed? So that is clouding her ability to make autonomous decisions. I think certainly we have to find out if the relatives have got any. We first of all have to clarify if she has got capacity. If she has, we have to respect her decision. If she doesn't, and that might require even getting a second opinion, then we have to make sure she's not depressed. If her relatives don't have any legal powers, and even if they did have legal powers, what can we do? Should we be putting down a feeding tube? What would you do? So that, we can maybe debate that in questions. That's one example of a case. And there's so many actually. I'll tell you what. I'll give you this was a case of a lady who I had many years ago. She was in hospital for a number of years. A 67-year-old lady who had extremely good health and was visiting the hospital and was knocked down by a motorbike and had a severe traumatic brain injury, which rendered her totally dependent, immobile, able to swallow, but not able to speak and not able to communicate in any other meaningful way. She could make noises and could move her arms, and that was all. She began to lose weight despite being fed a soft diet. Her daughter applied for welfare guardianship and was appointed welfare guardian. She had recurrent chest infections, which we treated with antibiotics. Her daughter was concerned about the weight loss. Although she could eat and drink, we did put down a nasogastric tube, which she pulled out. We put in a gastrostomy tube, which she pulled out. Her daughter wanted her weight loss investigated. She wanted feeding through a central venous line, and she wanted cardiopulmonary resuscitation if her mother had a cardiorespiratory arrest. And we had many hours over the years of conversation about what would be in her mother's best interest under these circumstances. Her mother eventually died a natural death in the ward of the consequences of her initial brain injury. But I had some interesting debates with the daughter about, to what extent do we intervene in this situation. If we had investigated this lady's weight loss by doing scans, what would we have done if we'd found she had a tumour? Would a surgeon have operated? And I think it's just an example of we have to make these decisions on a daily basis. I won't mention any other historical cases, but I mean, even thinking back on this week, I have two patients. One, yesterday I put a patient on the Liverpool care pathway, having discussed with her two sons. And earlier in the week I was asked to give a second opinion in a stroke rehabilitation ward on a man in his 60s who had a cerebral hemorrhage, who had had nothing to eat and drink for 3 weeks, and who was now virtually unconscious. And a repeat scan showed a worsening hemorrhage with pressure in the brain, and there was no neurosurgical intervention possible. And it was an Asian man, and the Muslim, of Muslim faith, strong Muslim faith, and the family a large family were divided. They were saying, on the one hand, he has to be tube fed because you can't allow him to starve to death. The other half of the family were saying, no, he's going to die, let him die in peace. And even those who had those two opinions would then switch opinions and change their mind. And my colleague, who was a consultant, had decided in consultation with the team that it would not be in his interest to put in a gastrostomy tube, but again felt sufficiently uncomfortable that she wished a second opinion. And we often do that, we go for a second opinion. I think the GMC guidance that the evidence in these situations, the end-of-life care of artificially assisted nutrition and hydration being beneficial or not, the fact that it's not clear-cut, I hope that in their updated guidance they may clarify that a bit, but it may well be that the evidence is not there, and we are going to have to continue that difficult decision of trying to decide what is in the best interest of the patient at the end of the day. And again, those of us, healthcare workers who have a Christian faith, obviously your practice as a clinician is influenced by your faith, and we also have to take into account the faith, the views of our patients as well, which may or may not be consistent with our faith. Anyway, I'm going to stop there so we have time for questions, and thank you for listening.